Bismillah ar-Rahman Rahim. Today on PSS podcast, we are having a session with our distinguished guest, Professor Dr. Shahid Sarwar Saab, on management of the Vericeal bleed. And we are really thankful to you. You have given us time. So we are thankful to Vericeal Pharmaceuticals with their collaboration, this is possible. So before, without wasting time, I'm asking a first question to you, sir. What are the basic management steps if somebody having portal hypertension and he start bleeding before initial resuscitation? How will he non-endoscopic, what are the non-endoscopic management that we can safely transfer the patient from the rural areas to a tertiary care unit?
Vericeal bleed has a very high mortality because obviously it's a catastrophe in a patient with cirrhosis. The most important thing in its management is the resuscitation because, and resuscitation means that we have to manage his airway, breathing, circulation, we have to maintain his pressures, we have to continue the perfusion of his organs. So most important thing is that once the patient lands into the hospital, you ensure that he has a good enough saturation. You ensure that his pressure is at least above 90 systolic or mean arterial pressure is above 65. So you take 2 IV lines, large bore cannulas, and you start with the IV fluids because that ensures that his perfusion will continue.
So you're absolutely right. We actually knew there are 30% mortality in first bleed of the Vericeal bleed, 30% mortality in Vericeal bleed in portal hypertension. What are the factors that actually increase the mortality in, and what are the predictors of mortality in patient with Vericeal bleed?
So it basically varices end up with bleeding because of the high portal pressure. It's the pressure which crosses 12 when it has. The higher the pressure is, the more likely is that the bleeding will be massive and it will be recurrent. So it's directly related to the stage of liver disease. And generally patients who are at an advanced stage of disease, who have got advanced CTP score, they are more likely to end up with a bleed which can result in mortality. That's the key factor in these patients. And the second thing which determines outcome, as I've already said, is how they are managed initially. That is the most crucial time in which if we lost some time over there and patient ends up with some organ failure, this will be something which will ultimately affect his mortality and outcome with the bleed. So these things, one is the stage of liver disease. The second is how aggressively have we addressed his initial management part or not.
So just you have elaborated very rightly, sir. When the patient is at rural areas and we don't have endoscopic therapies available there, and we don't have zinc stick in Blakemore or something else, so any drug that we can help the patient to shift before, and is it related to decrease the mortality? Are there any studies on that available?
Yes, because what happens is that generally once the patient bleeds, the portal pressure decreases, so bleeding stops. But it then again builds up, and that once the blood starts flowing again into the same veins, so it results in rebleeding. So there are drugs which can control and manage this particular problem till we have a definitive therapy in form of band ligation or that. So we have drugs which are basically vasoactive drugs. They function at the arteriolar level, so they are basically vasoconstrictors. They does not allow blood to flow to those veins from where the bleeding is taking place. So we have very good drugs. Initially we had sandostatin, that is basically octreotide, and now we have got terlipressin, which is vasopressin analog. These are the drugs which are very good at controlling the bleeding while we are continuing and we are in process of going for a definitive treatment, especially the scenario where you have said that you don't have endoscopy, you have to manage the patient without an endoscopic intervention. There the drugs are very effective because the bleeding will be controlled, you will have time in which you can perform your resuscitation, you can transfuse the patient and then transfer the patient to the tertiary care hospital.
Agreed. So what is your message for the PGs who are working in rural areas, that what the prerequisites they need to be seen in the patients, like if the patient are having ischemic heart disease, is it safe to give terlipressin in ischemic heart disease, or what is the advantages and disadvantages in the patient with ischemic heart disease along with upper GI bleed?
Because we know it's a vasopressin analog, and vasopressin is basically a vasoconstrictor, and initially the one which was used was something that was non-selective. Terlipressin is selective. It preferentially affects the splanchnic vasculature, but still there is a limitation in terms of that there is a little risk of having of precipitating an ischemic heart disease. So if we have option available, then octreotide, that is a better option because there are lesser chances of having ischemic heart disease. But obviously you are dealing with a life-threatening situation, and if you don't have any other drug, so then you have to use it very cautiously. Obviously you will need a baseline assessment, baseline ECG, and the medical record of the patient should be in front of you. If there is no other option, you don't have access to the octreotide, then terlipressin can be used, but it has to be done very cautiously.
Is there any reversal of these drugs available, like if the patient develops any cardiac ischemic event with these medicines, is there anything available to protect or actually treat the patient with ongoing bleed and ischemic heart?
It will be a very tricky situation because on one hand, patient is bleeding, but you obviously have nitrates. You have got the drugs which we usually use in patients with unstable angina or myocardial infarction. So, but then you have to balance it out because there is a risk versus the benefit. So if you are finding that having given terlipressin is resulting in an ischemic heart disease, obviously nitrate is the solution for that, which will reverse at least the problem that has been created.
So finally, you have elaborated very nicely. What will be your the message for the PGs who are working in rural areas and they are facing the problem with upper GI bleed?
My message will be not to avoid this particular complication, because one tendency that we have seen is that just refer the patient. No, that's not the right approach. First, give him initial resuscitation, try to stabilize him, and I can tell you at least 18 to 90% patients will stabilize once you give initial resuscitation, you arrange transfusion if the HB is less than 7 or at least 8. And use these drugs, terlipressin and these drugs which are available. They, for time being, for temporarily, they are very good at controlling of this. Once they feel that this patient is now in a safer situation and can be shifted, they need to collaborate with the tertiary care center where they are sending the patient. And obviously this shifting has to be done in a very careful manner, so as the resuscitation equipment, all that which may be needed during the transfer should be available. So it's a manageable thing in a
Thank you very much, sir. Thank you very much for coming. It is really nice talking to you.
Thank you.
Thank you.